In this video, we will go over esophageal tumors. So the two most common esophageal tumors are adenocarcinoma and squamous cell carcinoma, and we will be discussing these. We will begin with adenocarcinoma of the esophagus. As discussed in the esophagitis lecture, this is associated with long-standing GERD and Barrett's esophagus. There's also an increased risk for adenocarcinoma in patients with documented dysplasia on previous biopsies, tobacco use, obesity, or a history of radiation to the mediastinum. In terms of epidemiology, it is more common in whites and is actually 7 times more common in men than in women. There does seem to be a higher incidence in Western countries as well, and this should not be surprising given its close association with GERD and Barrett's. Adenocarcinoma does occur in a stepwise progression of GERD to Barrett's to adenocarcinoma. This occurs via acquisition of both genetic and epigenetic changes, including TP53 mutations. On endoscopy, adenocarcinomas are typically found in the distal 1/3 of the esophagus and grow as either ulcers with heaped up margins, an exophytic mass, or as a diffuse infiltration. And in the picture, you can see it growing as a mass into the lumen. They can also invade locally into the cardia of the stomach. So on histology, you can just appreciate the glandular formation, and there's often a lot of mucin production. So clinically, a patient will present with odynophagia, which is this pain with swallowing, and progressive dysphagia. Progressive dysphagia is difficulty swallowing first solids and then liquids. Patients may also experience weight loss, chest pain, and vomiting. In terms of the clinical prognosis, most patients will present with advanced stage at diagnosis, and so the 5-year survival rate is less than 25%. However, if it is limited to the mucosa or submucosa at the time of diagnosis, the survival rate is actually much greater at 80%. Squamous cell carcinoma is the other common esophageal tumor and is in fact more common than adenocarcinoma worldwide. In terms of the epidemiology, it typically occurs in adults older than 40 years of age. It is also more common in males, occurring 4 times as often as in females. African Americans are more commonly affected as well. Esophageal squamous cell carcinoma is associated with alcohol and tobacco use, which do have a synergistic effect, meaning alcohol alone and tobacco alone cause increased risk, but together they can cause a greater risk than just the sum of the two. So other risk factors include poverty, nutritional deficiency, caustic injuries such as swallowing bleach, achalasia, Plummer-Vinson syndrome, hot beverages, radiation therapy, polycyclic hydrocarbons, nitrosamines, and even high-risk HPV strains. On endoscopy, squamous cell carcinoma will be found most commonly in the middle third of the esophagus. So again, adenocarcinoma is the distal third, squamous cell is the middle third. Early lesions will appear as gray to white plaque-like thickenings, while later lesions will kind of form a polypoid protruding mass. Later lesions could also be ulcerated or diffusely infiltrative. They can locally invade the respiratory tree, the aorta, mediastinum, or even pericardium. On histology, they are moderately to well-differentiated squamous cells, and they can form these keratin whorls, as pictured in the slide. Clinical features of squamous cell carcinoma are similar to adeno in that the patient often presents with progressive dysphagia, odynophagia, and weight loss. Patients may also have hoarseness if the laryngeal nerve is involved. Patients can also develop a tracheal esophageal fistula, which results in aspiration. Other complications include hemorrhage and sepsis. In the case of squamous cell carcinoma, the overall 5-year survival is also poor, being 9%, but it does increase greatly to 75% if it is found early on and is still superficial.